So let's go back to that very helpful one-page referral pathway. So for those patients who we feel in primary care should be considered for an early EP ablation and referred to an EP cardiologist like yourself, let's now look at what really ought to be mandated components of the referral letter. I think Diraj has reinforced the virtues of initial investigations. Diraj, should ideally we be getting an echocardiogram in all certainly new diagnoses of AF? And if so, what in particular are we looking for?
I feel that a transthoracic echo is a prerequisite for all of these patients because this is a potentially major diagnosis. Yes, atrial fibrillation is ubiquitous, it's very common, but that doesn't make it a benign diagnosis. We often request investigations for lesser diagnosis. Now, once somebody has atrial fibrillation, it's almost inexcusable not to request a transthoracic echo. What we are specifically looking for are one of three things. First of all, you're looking for left ventricular function, because if the left ventricular function is impaired, then as we've discussed before, the onus on a quick referral becomes even more, because that tells you that whether it's atrial fibrillation that's causing the heart failure or LV dysfunction, or whether it was LV dysfunction, which is now made worse by atrial fibrillation, the time has come for you to act and act quickly. So left ventricular function is number one. Number two, you're looking for valvular function, in particular mitral valvular function, because sometimes atrial fibrillation can be the sign for a surgically correctable conditions of mitral regurgitation. And sometimes the patient may not have an auscultable murmur, which can be missed in a busy clinic room. So a transthoracic echo could identify significant mitral regurgitation, which needs action. So that's the number two reason. And the third reason is to look at the size of the left atrium, because that often gives you a clue as to how severe or how advanced the atrial fibrillation is. If the left atrium is only mildly enlarged or not enlarged, the success rates with catheter ablation are excellent. I would say 90%. If the left atrium is severely enlarged, as sometimes happens with neglected atrial fibrillation or AF that's not been managed proactively for a number of months or years, you can have a situation where left atrium is severely enlarged, and then the success rate with catheter ablation is also good. So left ventricular function, mitral valvular function, left atrial size. Those are the three things which every primary care physician can easily judge on an echo report.
Absolutely compelling reasons. If you've got access to it, let's get echoes on these patients prior to or as you're referring the patient for a specialist opinion. I'm not going to discuss this. It's obvious that all cardiology referrals, you should be getting a recent ECG. Let's give our cardiologist colleagues the information to confirm the rhythm, identify any potential structural issues like bundle branch block, any indications of ischemia, an up-to-date CHA2DS2-VASc score to assess stroke risk, and please also include a validated bleeding risk assessment like the Orbit score or HAS-BLED score. That should be included in the referral letter. And Diraj, can you clarify, please, the role of bleeding risk scores? They are often used to convince ourselves not to anticoagulate patients, but that's not really the appropriate use for them, is it?
Absolutely not. And also what makes the situation slightly more confusing is that CHA2DS2-VASc score and the bleeding scores, in particular the HAS-BLED score, tend to go hand in hand. So somebody who has a high CHA2DS2-VASc score would almost by definition have a high HAS-BLED score as well. That does not mean that the oral anticoagulation is contraindicated in them. In fact, if anything, it tells you that the patient is at a high risk of stroke. You need to certainly manage that with oral anticoagulation, but you need to look at the modifiable risk factors in the HAS-BLED score. For example, alcohol excess. For example, if the patient is taking non-steroidal anti-inflammatory drugs, which they can cut back on, those kind of things. But otherwise, the default should be put the patient on oral anticoagulation, so at least you protect them against stroke. And then the bleeding score can be then worked out in a bit more detail later on. For example, with Orbit scoring, if you're looking at kidney function and that kind of thing, all that's important, but not as important as CHA2DS2-VASc score and risk of stroke assessment.
Again, incredibly clear messaging. So clearly the EP cardiologist should be aware of the current and previous medications. So please make sure that's included both for the medications for rate control and rhythm control. We should also clearly document the anticoagulation regime used. And I think, Diraj, this would be an opportune time to check the patient is on the right dose of DOAC, because we do have good observational data that many patients are often underdosed in particular, and that can have potential catastrophic consequences, can't it?
Indeed, you're absolutely right. And I think it's just because a lot of general practitioners historically have gone by the adage, and I totally understand that first do no harm. So a lot of the general practitioners feel that stroke prevention may or may not occur in the future, but if a bleeding complication occurs, that's here and now. So they tend to be very conservative in managing the patient's stroke risk. And that sometimes takes the form of underdosing with the DOACs. I can't stress this highly enough that is not a acceptable or a safe strategy. In fact, it's the worst of both worlds. The patient isn't being protected against stroke, and yet they're still being exposed to the risk of bleeding. And in some DOACs, it's more often to be the case that you often end up with giving a patient a subtherapeutic dose. But now 80% of all patients who need oral anticoagulation across the board for any of the 4 DOACs need to be on the higher dose. So only 20%, whether it's apixaban or edoxaban or any of the, rivaroxaban, any of them, only 20% patients should be on the lower dose of the DOAC. And in almost in all cases, it depends upon the renal function. So I always ask the patients to one thing. I look at what the renal function is, and what the age is. So if the patient is less than 80, they almost all have to be on the higher dose of the DOAC unless their renal function is significantly compromised, so their creatinine clearance is less than 50 as well. So which tells you that more than 80% of your patients will end up needing the larger dose anyway.
Absolutely. So let's use this patient who we're going to refer, let's use that as an opportune time to just check they're on the right dose of their anticoagulant.